Welcome everyone to our 8th virtual morning business breakfast talk in our ongoing virtual event series Nexicom Presents Fourth Line Theatre at Home. I'm Kim Blackwell and I'm the Managing Artistic Director at Fourth Line Theatre. These sessions provide an excellent opportunity to get to know local political and business leaders and the inner workings of their sectors. I'm excited to spend some time this morning with Dr. Rosana Salvaterra, but before I do, I just want to have a few things I want to take note of. First, I want to acknowledge that I'm live streaming to you from Treaty 20, Michi-Sagig territory, and the traditional territory of the Michi-Sagig and the Chippewa Nations, known as the Williams Treaty First Nations, which includes Curve Lake, Hiawatha, Alderville, Scugog Island, Rama, Beausoleil, and Georgina Island. The area in which Fourth Line Theatre is situated is called Nojijiwanon, Ojibwe for place at the end of the rapids. The shores of the Odenabe River were a gathering place for Indigenous people. Odenabe, or Otonabe, means river that beats like a heart. We respect the treaties of peace and friendship and are thankful for the generosity of the Anishinaabe people in sharing their land with us. We would like to pay our respects to the elders, past and present. We would like to acknowledge that the Williams Treaty First Nations are stewards and caretakers of these lands and waters, and that they continue to maintain and carry out this responsibility for those here now and for future generations. Secondly, I want to acknowledge our amazing longtime sponsors, Nexicom, for their continued support and innovative approach to sponsorship during these unprecedented times. I would also like to acknowledge Exit Realty LifeLock, our major sponsor. Thank you both. Some housekeeping notes. I just want to let you all know that your audio is muted. If you would like to submit a question to Dr. Salvaterra, we would be happy to answer your questions during the Q&A at the end of the talk. To ask a question, simply click the Q&A button on the bottom of the menu of your Zoom video window, and then you can type the question and Lindy, our host, will collect them and give them to us during the Q&A. Also be aware that if you mistakenly exit the webinar or have any technical difficulties, you can re-enter the webinar by clicking on the Zoom link we sent you earlier today via email. Just get back the same way you came. Be sure to follow our social media and e-blasts and visit our website to learn about our upcoming events. And you can also visit Fourth Line Theatre's YouTube channel to view all of our virtual events after the live presentations. And now I would like to introduce and welcome Dr. Salvaterra. Good morning.
Good morning.
How are you this morning?
I'm good, thank you.
Good. I like all your blue. You're in blue, your room is blue.
Oh, it's a peaceful color, just like
I really like it. So tell me where you're coming to us today from.
So this is my dining room. I'm coming to you from my home here in the downtown of the city. I'm one of the lucky, I'm a pedestrian. I get to walk to and from work every day. So that's a real treat for me and very important for me. So yeah, I'm at home this morning.
That's great. Now, I want to talk to you a bit about your time when you were the Chief Medical Officer of Health in Stratford, because you've made up for all those years of traveling from Toronto to Stratford now by being able to walk to work, yes?
That's correct. That's correct. For 3 years, I commuted. I would go Monday and stay until Friday. I lived with the former mayor of Stratford. We were great roommates, and she was a wonderful host. And a great way to get to learn about the community and get to meet a lot of the people. So I had a wonderful time in Stratford.
That's great, but it's nice that you get to walk to work. Now, you have not been homebound throughout the pandemic, because I talked to you yesterday when we were doing our dress rehearsal for this, and you were at the office.
Yes, I have spent, I would say, most of my time at 185 King Street. I have an office there that I work out of, and I do usually go in early and stay late. This is a bit of a treat this morning to be able to stay home a little longer and to have this conversation with you from home.
Well, thank you so much for joining me. I was thinking about it in the shower this morning. You're like a real get interview for me, because you are sort of, and I don't know, like you're the most well-known person probably outside of the mayor in the city, right? In the last 14, now almost going into 15 months.
Well, that's too bad, isn't it?
I know. I kind of wish we didn't know so much about you, because then we wouldn't be in a pandemic. But right. I think it's so important to get to know you, and I'm so interested in your career and the path that brought you to sitting here with me today in Peterborough, in the middle of this pandemic. So I wanted to ask you, so I read in something that you're born and raised in Toronto?
Mhm. Yes, I was the first Canadian-born child for my parents. They were immigrants from northern Italy. They were quite scarred from the deprivation and the trauma of World War II. And really, for them, Canada was a chance for a new beginning. It provided so much opportunity for them to raise a family here. So they came to Canada in the 50s. My father came as an agricultural worker, and then sponsored my mom and my sister. And I was the first Canadian born here in Canada.
Wow. And what was that like? So you're the second of five kids ultimately, yes?
Third, I had a brother who died soon after birth. And so I'm the third in the family, right in the middle.
Okay. What was it like being the child of immigrants? I mean, I guess you don't know anything else, but were you aware of it at the time?
No. No, and in fact, my mom never learned to speak English. There were enough Italians in Toronto that she could earn a living staying in her mother tongue. And so, she took me to school when I was 5. I didn't speak English either. And she left me there, and they mistakenly put me in grade 1. And I didn't know any better. Neither did my mother. So I've always been a year younger because of a mistake that was made, and nobody knew any different.
Oh my gosh. So now you were originally raised in that St. Clair and Dufferin area of Toronto, right? So this is it the second Little Italy? Because I think of it, I mean, I'm thinking of, college, and then I think of St. Clair and Dufferin.
Yes, it would have been the second. And then, of course, from there, it moved further north up into Woodbridge now.
Yeah. It's funny. I was talking to a friend of mine last night on the phone. He's in Toronto, and our favorite restaurant, because I was 19 years in Toronto, we've just moved back to Peterborough last year, but our favorite restaurant in Toronto is owned by our friends, the Piantonis. It's La Bruschetta. I don't know if you know.
Yeah, yeah, on St. Clair?
On St. Clair.
Sure, I know it, because I worked in the area as a family physician for many years as well. So yes, I know that restaurant.
Yeah. So he said you have to ask her if she knows. I'll have to email Sylvia and tell her too that owns the restaurant now. But anyways, but you guys eventually moved to Downsview. Was it Upwardly Mobile? What was happening there?
Yes, my parents bought their second home, and it was in Downsview, in an area that had not seen many immigrants. So traumatic move for us, because suddenly we were the targets of a great deal of discrimination. And I mean, I was bullied. I was physically bullied as well. They called me WAP. And I had no idea. I went home and I said to my parents, the children at school, my friends at school are calling me a bug. Like I thought they were saying wasp, and I thought it was a bug. And I hadn't heard that term before. And I remember being perplexed and asking my parents, why were my school friends all calling me this name? So yeah, it was not an easy transition into a non-immigrant neighborhood. There was quite a lot of prejudice against Italians at the time,
Yeah.
and we certainly lived that.
Wow. And was it more isolated? Something I read said that the house, and I don't know if this was the house in Downsview and at St. Clair and Dufferin, but that was always filled with extended family.
Well, that was while we were at St. Clair, my mom actually had boarders. And so the home not only housed us as a family, but housed 3 or 4 single Italian men who had come over as immigrants and who were, earning money and trying to bring over the rest of their family. So, and my mom fed them, and of course the house became a bit of a magnet for others. So there were always people over, and they were either, friends or family. My father played the accordion. He made homemade wine. My mother cooked. She loved having people over. And so the house was always full, and that was one of my earliest memories of growing up, is that there were always people, and there was always, and it was such a welcome thing to have people coming into your home. There wasn't anything. I mean, these were immigrants so far from their homes who thought they would never, ever go home again at that time. And all they had were these others, you know, who came from the same place. And so gathering together was really, that was the main form of entertainment we had, was social gathering with these others.
It's so funny you just used that phrase, and we'll talk about it a bit later, social gathering. So, because that is the thing we cannot do right now, I know, and that we're all missing. I could probably talk to you about this for forever, but I have to start talking about your education and your career. Was there an expectation that you were all going to go to university out of, like in your family, was education the thing?
No, I mean, my parents had had their education disrupted by the war. They never completed even grade school, unfortunately. And there really was no expectation that any of us would go on to post-secondary. I mean, as it was, I mean, the fact that my sister completed high school when her classmates were all leaving school after grade 8 and getting married. So my sister finished high school. I think that was the expectation, was that we would complete high school. When I told my parents I wanted to do university, it was really, well, you're on your own, you know. First of all, girls, you're a girl.
Right.
And secondly, you know, what's that? I don't know if they even knew what a university was.
And did you just know intrinsically that was what you were going to do, or did you have teachers that knew you needed to do that, or a guidance counselor? Where does that come from then when it's not in the house?
Oh, I loved learning. I still do. I'm a lifelong learner. I hungered for school, and given what was happening at home, school was my refuge. It was, you know, it was a lifeline for me. And so, yeah, there was never any doubt in my mind that I would continue to learn. I think I wasn't quite sure of what I wanted to do. I'm not sure if you found in your research that I went to India after high school, but that 2 years that I spent as a volunteer in India really was quite transformative for me, because I had thought I had wanted to do medicine before, and then I went to India and realized that, you know, much of medicine is a band-aid. You know, we're not, and that really what I needed to do was focus on what we call those social determinants of health. You had to address poverty, you had to address housing, you had to address literacy. And so I came back, and instead of going into medicine, I did sociology. So, you know, imagine that. And I didn't really get back into medicine until I'd had my own 2 children. And it was really my work in First Nations communities that kind of steered me back into medicine.
So that's so interesting, because that's what I wanted to know, and I want to ask you more about that. So I think I conflated. You went to Pakistan at the end of high school and did something at a refugee camp, and then went to India and worked for 2 years. Is that what it is?
Close, but you know, you've got it. I mean, what happened was I went to West Bengal, and I went there because when I was in high school and I was on student council, and we were fundraising. The War of Independence for Bangladesh, that was 1971, occurred, and there were refugee camps in West Bengal, and we fundraised for those refugee camps. And it was the Canadian Jesuits who were in West Bengal who set up these camps. And while I remember being in the auditorium, and we had a film and a speaker, and on this film in the refugee camp, there was this Canadian, and she was a young woman from Edmonton who was volunteering in the refugee camps. And I looked at that and I thought, you know, I'm a year younger than everybody else here. I have lots of time right now on my hands. Why not? You know, why not do something like that while I can? And I decided, yeah, I'm going to do that. I'm going to go, and I'm going to volunteer in the refugee camps in West Bengal. Well, by the time I actually finished grade 13, the war was over, thank goodness. And the camps were no longer there, but I did use the Canadian Jesuit connection to go to West Bengal, and I ended up in Darjeeling. It's famous for tea. in the Himalayas, in a community health center that did both social programs as well as health programs. And I spent 2 years there working and learning. I mean, as I said, a tremendously transformative experience for me. And I would not have come home had I not made that promise to my parents, because they certainly couldn't understand why I did this, why I wasn't just getting married and having children. So I had said to them, look, I'll do it for 2 years and then I'll come back. And so I kept my promise, but I must say it was heartbreaking. I mean, it makes me want to cry. It was heartbreaking for me to come back. I did not want to come back. Darjeeling is really, I have a soft spot in my heart for Darjeeling.
Oh my gosh, that's fascinating. I just want to ask you something. Have you been back since then?
So I came back because I promised, but I did the world's fastest undergraduate degree. I did my undergraduate degree in 22 months. I worked around the clock. I stayed up all night. Once a week, I pulled an all-nighter. I went through the summer and did courses in the summer, and I took the first plane back to India in 1978, and I had studied Paulo Freire and the pedagogy of the oppressed and the role of literacy and really, in empowering people to making them aware of their situation and giving them the tools to be able to change, their lives. And I went back and focused on literacy in 1978. But at the time, the area was quite unstable. There was an independence movement happening among the Nepalese, the people living there, and the government exiled me. They first they prohibited me from going into the villages because we were doing our adult literacy programs in the villages. And we were using adult literacy as a way to help people learn about cooperatives. I mean, I don't know if you know about the Coady Institute and St. Francis Xavier University in Antigonish and the Coady movement, very large internationally. It's all about cooperatives and credit unions. And so we would use adult literacy as a way to introduce this idea of cooperatives, and people would form milk cooperatives or housing cooperatives. And so first of all, they told me I couldn't go in the villages. So they stopped me from going in the villages because we were seen as a threat, foreigners. And then they gave me 48 hours notice that I had to get out. So I came back to Canada, again, heartbroken. And landed in a job in Toronto as a youth organizer, working with youth, and that's where I met my husband. So in a way, it was great that I was exiled, and as they say, the rest is history.
Right. Well, that is so fascinating. So, was there a moment you're doing the youth work in Canada? You're back. Was there a moment? Or is it an epiphany moment to decide to go to medical school, or what happens?
No, I mean, medical school was not on the cards for me right then. I loved my work. I really saw my work as a community organizer, and my work with young people was to broaden their horizons, expose them to the idea of justice, social justice, peace work, and I would take young people to the Dominican Republic and Haiti, and have them reflect on that experience and on the whole social structures, and then we did a lot of anti-nuclear work. We started the cruise missile conversion project, which we used to do demonstrations at Lytton's, and which manufactured the cruise missile. So I did a lot of activism work, and that really was where I felt most at home. My husband and I did go to work after we were married. Again, it was a bit of a fork in the road. I had been accepted by the Mennonite Central Committee to go as a volunteer to Brazil, to Recife. But love intervened. And then we had to decide, do we go back and do international work? Do we stay in Canada? And we recognizing the terrible inequities here in our own country with Indigenous people, we decided we'd stay and we'd go and work in Indigenous communities. We were so naive, but well-intentioned. And it wasn't until I was immersed in that work, and it was with the North Shore Tribal Council, so the North Shore of Lake Huron, 7 First Nation communities, working there with women and recognizing that health was such a motivator. I mean, if women felt that their health of their children was threatened, they would just, they'd rise to whatever the issue was. And I just felt, I'm in over my head. I have so much to learn. I don't have enough training here. I need more education. And I went back to that theme of health and medicine, and I applied for medicine, and with the intention of doing community health and working in communities and using that as a way really to bring communities together to identify issues around health and then to assist them in addressing those issues.
And well, so that obviously that comes full circle to what you are doing right now, I think. And I'm curious, so you went to McMaster and you did your MD and then you did a family medicine residency, yes?
I did, and then I started my master's and that's how during that program, I went back to the North Shore Tribal Council, and they ended up hiring me as their senior health consultant to assist them with health transfer. So I was able to get back up and do some work for them, and then focused in on family medicine. But I did a year of training as well. Family medicine, I did an extra year. And again, I couldn't decide. I loved family medicine. I loved obstetrics and women's health issues, but I wanted to get back to the determinants of health. So I created this 3rd year of training and applied for it, and I was funded. So I did half of it was on women's health and half of it was public health. So I did that extra year and then decided to stick with family medicine and do obstetrics and work with refugees and other vulnerable groups. And I did sort of public health on the side as a volunteer. I was appointed to Board of Health in Toronto, City of York. I became the chair of the Board of Health there as a family physician, and then was appointed to the Toronto Board of Health as a citizen appointee. So I did public health sort of on the side and focused more on family medicine for about 13 years.
Wow. So, but you at some point you're in Hamilton and you, with a group, with some friends, you create a clinic for refugees.
Yes.
And start working in HIV/AIDS. Where does that fit into all of this?
So that was during my family medicine residency and that additional year that I did. And then the Department of Family Medicine hired me as what they called a clinical scholar to help teach family medicine residents. And in fact, some of those family medicine residents are here in Peterborough. They're family doctors. So it was great to come here and to meet them again, 30 years later. So I stuck around in Hamilton in a community health center. We did begin a refugee health program there. At the time, it was mostly Somali refugees who were coming in from the border, the Niagara border, crossing there and coming up. And Hamilton is really the first big urban center. So many of them settled in Hamilton. And our community health center created this clinic and we provided care for these refugees.
So something I was reading said that you were the largest HIV/AIDS practice here. You had the largest HIV/AIDS practice in Hamilton. And are we now into the late 80s, into the early 90s?
We're into the late 80s. So as I was doing my residency, HIV was emerging and we actually finally understood what it was. And at that time, many of the people infected were either people with hemophilia who had tainted blood products, or people who, or gay men, essentially. And they were pariahs. We, where I was doing my residency, where I did my third year and then became a clinical scholar, there was another physician there who had an interest in HIV. And so together we took on all the HIV patients. Nobody wanted them. People were turning them away. So we had a large practice of people with HIV. Because I did obstetrics, became one of the first physicians to do obstetrics with women who were HIV positive. So that was a focus of my work in Hamilton, before I moved to Toronto.
I'm curious with that I was thinking back to last March and April when we didn't know COVID maybe the way we know it now. And, I was saying to someone recently, we know it's not as deadly as Ebola, but it's more contagious than Ebola. I don't know if that's true about COVID. That's how I describe it to people. But when you're working in the unknown, so when HIV/AIDS is unknown, how you could get sick or how you could get it, or how do you navigate that as a physician treating patients with HIV/AIDS in that period?
Well, that's when we adopted what we call universal precautions. So what we learned then is that, people with HIV didn't come with a label. You don't have HIV on your forehead, thank goodness. So really, when you're dealing with body fluids, you need to treat every specimen as if it could potentially be contaminated. And so we learned about how do you do that? How do you actually practice universal precautions so that you don't, you don't contaminate yourself, you don't contaminate others. And so I really think we learned a lot about infection prevention and control in the 80s. I think we learned it the hard way, unfortunately, but we had to do something to address the stigma and the unknown. And that is that we behave in a way where you have to take the precautions that will be the most protective. It revolutionized really how our infection prevention and control practices.
And do we still carry those through now, over 30 years later? I mean, when people draw blood, do they treat like every blood draw anywhere in this country or in this province, I guess, could be infected with something?
That's correct. Yes. So now we've all learned how to do that, and we have the procedures in place and the equipment. And so that is how we deal with everything that's potentially we call a hazardous product or substance. Yeah.
It's interesting because I wonder, I'm going to ask you in a while what you think will take forward from the COVID pandemic. And I'm wondering if masking will be with us sort of forever. It's funny to watch medical dramas on television. I was watching one the other night where they're not masked, in the emergency room. But do you think that there will be things like that will move forward, that will become with us forever in a good way?
In a good way. I mean, we do know there are other cultures where masking is more normalized. And we certainly have learned from COVID. I mean, we have not had a single case of influenza this winter, and it's because public health measures work. And so distancing more than anything, because I worry about masks because they can give people a false sense of security, and then we get too close. But there is a role for masking, both for people who have symptoms. So, and we've done that. We've always had, we call it respiratory etiquette. We ask people that if you are symptomatic, that you not come, but if you do come, that you wear a mask. And we've always had masks available. I think we should see more people being aware that, yes, I have a symptom, I need to protect others, I should be wearing a mask. And hopefully we'll keep some of those measures, because influenza is with us every year, and people get sick and die from influenza. So I think hopefully some of the lessons from COVID will help us in the future with some of our other infectious diseases that pose risks to us.
Yeah, it'll be interesting. Yeah, my daughter, I just quit. My daughter was at a school in Toronto for 10 years, and the kids in the high school were predominantly kids from mainland China. She was in the elementary section of this school. And every year in the fall, they would start masking the kids. And we would think, oh, it's so strange. What are those kids doing? It's such a weird thing. Now I'm like, they had protocols and etiquettes around if they were feeling ill, obviously, because they're from a much more populous, densely populated place in the world, I would suspect.
Probably, yeah.
Yeah. So you're in Hamilton, you finished the 3 years. You did the part of your master's was a health research methodologies as well, right? So obviously you're not just, not that you're not just, but I mean, you obviously have this incredible belief in public health in terms of determinants and getting to the grassroots of problems before they become major physical issues. But you also interested in numbers. Are you a kind of a numbers geek?
I'm an evidence geek. I like knowing the rationale, having sound rationale for what I do. And I like to make sure that we use evidence to inform our practices. So back in the 80s, when I was learning about it, it was called critical appraisal, really critical thinking. And I've stuck with that. Especially when it comes to public health, I think it's important that we use evidence to inform where we have it to inform our practice. And we want, because, our time is limited, resources are limited. If I'm busy doing something that makes no difference, then I have no time or resources to do what really does make a difference. So I do believe very strongly that we have to be evidence-based, and that it should direct our choices in what we do or don't do.
Makes sense. So now you're doing your family medicine practice in Toronto. And so why does one want to become a chief medical officer of health anywhere? What's the choice when you threw your hat in the ring for Stratford to start with?
Well, yeah, I mean, at the time, I was on the Board of Health, so I certainly was cultivating my interest in population level health and public health. And it was because of my work on a Board of Health that I became aware that we had a shortage in Ontario. 1/3 of the MOH positions were vacant. And again, it's not a job that that everybody wants to do. And so there were vacancies. And at the time, the province was recruiting family physicians to who were interested in public health, essentially saying that if you commit to doing a residency and being trained as a public health specialist, we'll pay for your residency, and then you in turn have to go to an underserviced area to work. So I was aware of that. My kids had just left home. I had a bit of an empty nest going on. I love to learn. Wow, school. So I decided to throw my hat in the ring and go back into a residency program and become a public health specialist. So I did that, and Stratford was looking for an MOH. Their MOH was retiring, and so I was hired at Stratford, and I was hired for a year. All I had to do was a year, but I loved it, and I stayed 3 years.
Wow, that commute, I can't even. Okay, so I am curious if you can break down for me, what does the Department of Health do, public health do in a community before the pandemic? Let's talk like in the before times, and then we'll go into now. But typically, what does the public health do in an area?
Well, public health is really the interface between municipal services and the healthcare system. We work with both partners, so we do everything from ensuring that drinking water is safe, that sewage is correctly treated, that we look at environmental issues like rabies and Lyme disease, air quality, and we also support the healthcare system in preventive medicine. So all the immunizations, we provide immunizations to all our physicians and nurse practitioners for childhood immunizations and adult immunizations, but then we go into the schools and we do immunizations of school children. We support schools for school health programs, whether it's mental health, physical activity, prevention of substance misuse. We focus on the prevention of chronic diseases. So much of the work, I say we are the cathedral builders, because, it takes often a century to build a cathedral. And the people who start building the cathedral, they're not alive to see the cathedral finished. But public health, we're the cathedral builders. We're the ones who identified, smoking in indoors kills people. And so we need to make our indoor spaces smoke-free. And the benefits of that, there are immediate benefits. We saw hospitalizations start to drop as soon as those bylaws came into effect. But some of those benefits you don't reap for 20 or 30 years because they're lung cancers that are prevented. So it is very much about social determinants of health. It is about addressing inequities, because many of the poor outcomes that we see are worse because of social inequities. So poverty is a huge risk factor for most diseases and most poor health outcomes. And so part of our role is identifying those inequities, identifying what strategies are useful, providing that advice to decision makers like local governments or provincial governments or federal governments, and trying to influence those decisions in order to make healthy choices for communities. So my patient is the community, and my tools range anywhere from inspections to immunizations to healthy public policy to a sexual health clinic. So I have a variety of tools in my quiver that I can use. And I have to be patient, because sometimes it takes decades to see the results. I think one of the things that really excited me about public health and about being anchored to municipal governments was the story of the pasteurization of milk in Ontario. I mean, long before we had a law that made it mandatory to pasteurize milk, it was discovered that that milk was not safe and that it was creating a lot of illness, and many children were dying. I mean, it was the leading cause of death in Ontario. And it was municipal bylaws that came first. It was medical officers of health working with their municipal councils, introducing municipal bylaws that required milk to be pasteurized, that came first. And the provincial legislation took decades. They lagged by decades. So if you want to be in a place that's innovative and that's responsive, that's at the municipal level, and that's where public health is here in Ontario.
It's so interesting, because one of my questions I had for you was, right before the pandemic last year, the present provincial government was starting to talk about the fact that 34 medical officers of health were not necessary. 34. I assume you remember this? Yeah. So they were talking about centralizing and streamlining. And I've got to say, as a layperson, I was like, well, that seems to make sense. I mean, those are 34 big salaries and 30, but you're saying that, were you kind of because of the grassroots nature, as you're describing it, were you pulling your hair out at the, I don't want to say idiocy, but I'll say idiocy of that kind of a thought? Or like, what do you think when you were hearing all that?
Well, I don't know if it was the medical officers of health that were the problem. I have a feeling it was more boards of health, because just think of it. There are 34 boards of health that are composed of municipal appointees, because municipalities help to fund public health. They pay for a part of it, but also provincial appointees, citizen appointees. These boards of health meet monthly. They look at their communities. They are advocates for their communities. If they don't like provincial policy, they are vocal about that. They make their views known. They are the go-to place in the community when people have issues of health, where they're concerned about their health. Where do they go? They go to the Board of Health. They make a presentation, and they advocate. I mean, look at what happened here in Peterborough with asbestos back before my time. I mean, it was GE workers who went to the Board of Health who said, we have a problem with asbestos. And it was the Board of Health that advocated to get WSIB clinics here to assess these workers and identify those who had asbestosis or who had been exposed to asbestos. So boards of health, they are, to me, that's what's critical. It's the Board of Health. And they can be a thorn in someone's side. And so I think that was really the intent. Medical officers of health, yes. We are independent. We are accountable to our boards of health and to the Minister of Health. We will speak up if we see a problem, and we have the powers to address a problem if we believe it exists. I think it's critical to have that person so connected to their community and so aware that we can act in a timely way. I act in hours. It doesn't take me weeks or months or years to fix something. I have the potential to step in immediately. And so I really cringe when I think about what the intent was a few years ago to actually potentially eliminate boards of health, and also with that eliminate having a medical officer of health that's looking out for their community.
Yeah, because it's interesting as you talk about it. Of course, I realize now communities and how the province has been segmented up. It's so key because this community. I'm curious about when you got to Peterborough and started the position. What were you surprised about in terms of like, oh my gosh, like where were the gaps, or what was the big thing facing you?
Well. There were definitely gaps in our staffing. And I mean, I think I understand it because having worked in Stratford, I understood rural communities and rural boards of health. First of all, rural people are incredibly self-sufficient and resourceful. And if they're going to do it themselves, they're not going to rely on government to do it. They're going to do it themselves. And they pinch pennies. They had to, they're frugal. My parents pinched every penny they came across. I'm also, I understand that. But what I think the danger of that is that then you get a public health department or, that is underfunded and under capacity. And I think that's really what I discovered here in Peterborough. I mean, I think it's a wonderful mix here because we have the city, we have the rural area, we've got First Nations. But in general, I would say compared to other local public health departments in the province, Peterborough was under-resourced. We spent less money, we had fewer staff, we were more stretched. I think part of my work over the last 13 years has been to try and very prudently, because I know money, resources are scarce. And as I said, there's always opportunity costs. If you spend here, it means you don't have enough for here. So I think within that context, identifying those gaps and trying to fill those gaps and attract the staff with the skills that we need here in Peterborough to address the issues. And I think we're better than we were 13 years ago. We are still stretched though. I mean, I have some of those fundamental critical roles that public health fills for our community. Some of those roles are being filled by one person here. And if that person goes down, including your medical officer of health, I have no backup. And so we're thin on the ground, we're stretched. I think I'm very proud of the work we do. I think Peterborough Public Health is awesome. We have a wonderful team. We have a wonderful board. We do amazing things with very small amounts of money. We have tremendous volunteerism here in Peterborough. I think you know that as well. And we make it happen. We make it happen. We find a way.
Well, it's so interesting you say that. I did I've been volunteering at the vaccination clinic at the Evinrude, and when they did the morning go around with the announcements, of course, there's public health nurses there who are managing it all. And then I looked around and I saw 30 volunteers, and I thought, without volunteers, it would not be happening. I couldn't believe that was for the morning shift. There were 30 of us there, and all needed. Like I was busy, for my shift. It was very interesting. I want to ask you about if you remember two things. One is the first time and where you were and what the circumstances were when you heard about coronavirus. And
Yes.
then the second part of that is, do you remember the moment and where you were when you thought, oh, this is going to be bad?
Well, I had an inkling of it the first time I read about it, and it was in an email. It was December 31st. So last day of the year, I was in the office working. Tends to be quiet time of the year. So I was reading emails coming in, and I subscribed to a service called ProMed. It's an international network of infectious disease specialists and public health physicians. And it's a bit of an intelligence sharing network. And there was a posting from Wuhan, China, saying that there had been many deaths due to a severe respiratory syndrome, unknown cause. And I mean, we've learned from SARS, we've learned from H1N1. I mean, all of those started the same way. So my tentacles went up what is it? The hairs on my head.
Yeah. Your hackles went up.
I got you. My kids, that's what my kids would call them. And I thought, I have to watch this. And so sure enough, by the first week of January, we were getting emails from the provincial, from the Chief Medical Officer of Health here in Ontario saying that things were not looking good, and that we were learning more, and we were concerned about what was going on in Wuhan, China. So that was really the first time. And again, in my job, you learn to be to wait to get evidence. I mean, it's a bit of a balance. You need to act early because you want to prevent, but on the other hand, you don't want to overstep. You want to make sure that what you're doing is measured and it's based on evidence. And so, we still didn't know what this was. We didn't know how it was transmitted. And yet thinking, okay, this might be big. This might be big. We might be looking at another pandemic. We'd learned from H1N1 that even when the organism was being identified in Mexico, we already had it here in Ontario because of all those teenagers who had gone down on March break to Mexico and had brought it back. So typically we learned that by the time you understand what it is, it's already here. And that was actually what happened again with COVID.
Wow. And so I'm curious, I'm thinking of SARS and MERS and H1N1, and I remember going to a vaccine clinic in East York and getting my daughters and mine the H1N1 vaccine. And have you been getting ready for a pandemic at the public health level for decades? Has everybody been ready? I mean, I know we weren't ready with PPE and things like that, but has everybody been expecting it?
I think since SARS, yes. So SARS was 2003. And we learned then that we needed to be ready. And so pandemic preparedness became a mandatory public health function, 2003. However, I think we all expected, and then H1N1 came along in 2009, and we had pandemic plans for H1N1. We used them and we refined them after H1N1. And I think after H1N1 and after SARS, what we found was, so SARS was coronavirus, we were able to nail it. We were able to contain it. Influenza, no. And so I think those experiences sort of made us think, well, when there is a next pandemic, it'll probably be influenza. And so I think the experiences of SARS and H1N1 in everybody's mind, we were thinking we were preparing for the next influenza pandemic. So COVID took us a little bit by surprise in that it's not influenza. And so we had to rewrite and refashion our plans. I mean, but again, you know, so much changes. We don't, even 10 years ago, we didn't have the technology we have now as far as being able to set up. We now have a provincial system for both the booking of all the appointments. So you can go on, you can do it online. You know, we didn't have that with H1N1. People had to line up. I don't know if you remember, but in H1N1, you lined up and waited for hours in a line. You know, with COVID, we can't do that. We have to physically distance. And so lineups are out of the question. And so we're doing the booking online or by phone. And not only, I don't know if you remember, but at the Evinrude, people use iPads. The immunizers come to you with an iPad and they enter all the data in electronically, and then it captures your immunization. It captures the time you were immunized, the lot number of the vaccine you were given, and it tells you when you're due for your next one. So we didn't have these tools back when we were planning the last pandemic. So part of it too, I think, demonstrates the need to be continually updating and to be learning new tricks. You know, the old lessons can only get you so far. You have to be innovative. You've got to be adaptive and flexible. And if anything, COVID has been another lesson on how important adaptability and flexibility are, because things change with COVID. You know, in a day, things change. So it's constantly changing. What you think in the morning might not be true in the afternoon and the evening.
And so what has the workload been like for the last 14, we're almost starting our 15th month in 2 weeks of this, for you and for the team? I'm curious about how people have managed it. Like, have you had any time off? Is that an impossibility?
I had a couple of weeks off in August, but I've had otherwise no time off, and neither has my staff. I mean, people were allowed to take 1 or 2 weeks. This year, where we've asked people to try and take a week. It's not always possible depending on what team you're on. So I know people have gone without holidays. We're a 7-day-a-week operation. We're working around like 7 days a week, 24 hours. So it means that people have been doing a lot of overtime. I know we've had to pay out a lot of vacation time because people weren't able to take it. I think staff are stretched. I think they are feeling the strain. And right now, I worry about burnout for my staff. You know, you can push yourself only so far for so long. And I really feel we're at that. I mean, we knew it was going to be a marathon. We knew it. We're feeling that now in our bones.
We were talking about it earlier. We're not good at, as human, the human psyche isn't good at not knowing the end. Like if we were told it's 20 months, we'd all organize our brains around that, but there's no way of knowing. I am curious about how you think it will end. If you put your crystal ball out of the cupboard, how do you think this will end for us?
Well, I look to places like Israel, where they have now immunized most of their population. And what happened there is that by the time when they got about 60% of their population fully immunized, so I'm not talking about 1 dose, I'm talking about 2 doses, they started to see things going back to normal. So transmission was being interrupted. There were fewer cases. So, you know, we talk about herd immunity. What does herd immunity look like? What will it take to get to herd immunity? Eventually we'll get there. We may, given how much immunization, how many vaccines the federal government has been able to procure, it looks like we might get there by the summer. We might be in a similar place to Israel now by July and August of this year, where we might be able to see things going back to normal. And we may be able to relax some of the public health measures. So I think time will tell. And the data will tell. I mean, we should start seeing the numbers of cases go down, the hospitalizations decrease, the ICUs should become emptied again. I mean, that should be driving us. It should be evidence-based. We should be driven by what we are seeing. And so I'm looking forward. I'm thinking summer, end of summer, that we should be in a much better place.
Because it's a bit of a fulcrum, right? Like I was thinking about this in the shower this morning. If we didn't got nailed with, like if I look at first wave, and I now look back at first wave numbers on Worldometer, and I'm like, oh my Lord, we thought we were in trouble then. Then you see the January second wave numbers and you're like, those were so scary. And now you see third wave numbers, but is that balance between vaccines and transmission will eventually change as you're talking about, but is it the variants of concern that are whipping us right now? Like if we had vaccines without variants of concern, we wouldn't be here. Yes.
Yeah, well, it's sort of the variants of concern, though, are a result of the widespread transmission. I mean, viruses replicate very rapidly, and each time they replicate, there's an opportunity for a mutation. And so the more replication you have, the greater the drive to mutants and to variants emerging. If you can stop transmission, if you reduce transmission, you don't have as much risk of variants emerging. And so right now, that's what we've experienced with so much transition going on in parts of the world. It's we've seen more of these variants emerging. But I do think it also reminds us that this is not a Canadian problem that we can solve. It's an international problem. You know, if you've got lots of infection happening in other parts of the world, these variants will emerge. They're going to affect us. You know, we can't just be thinking of ourselves. We have to be thinking of this globally. And there are a lot of countries that don't have the resources we have, that don't have the healthcare systems we have. We're seeing that right now in India, a place I know well. And we can't just be thinking of ourselves. We have to do this together. And we won't beat COVID until we beat it as a world, you know, as a global community.
100%. I have to get to questions because I don't have much more time with you, but I do want to say that is some of the challenges of life, is the personal and the global, right? Like we all want to be vaccinated because we're so afraid of getting it ourselves. And then once we are, well, then we can look to other people, right? But it's about finding that balance that I think we all struggle with. I could talk to you for hours more, but you have an actual real job. And I'm so grateful for the time I've had with you. And I don't want to say goodbye yet, but Lindy, do we have some questions for Dr. Salvaterra?
We do. Thank you. Yeah, so I'll start off with a comment from Sherry. She says, thanks, Kim and Rosana, for this lovely coffee conversation. And I just want to start off with a question from Heather. Given the current importance and recognition of public health measures and social determinants of health, do you think there will be a shift of government funding priorities towards prevention of disease and adherence to the precautionary principle?
Well, one can always hope that living through a pandemic will illustrate the importance of investing in public health, and also that prevention makes so much more sense than trying to fix people up when they're already sick and, you know, ventilated. One can only hope, but I must say, prevention is not sexy. You know, we don't have the same sex appeal as, you know, crowded emergency rooms or, you know, whatever. I mean, we find it hard to compete. And you really do, you need you need leaders who understand and recognize the importance of these kinds of investments, because they are investments. Public health is an investment in the future.
Well, you need cathedral builders, to use your language.
Cathedral builders, right?
I love that. I love that.
And so I think it really falls to the commitment of leaders to prevention and to making those investments and recognizing how important they are. You have to have a vision. Like, you know, you've got to be visionary, and you have to be committed to that.
That's great. Thank you. Our next question starts with a comment. What a remarkable woman. We are so fortunate to have you here at the helm of PPH. It must be so heartbreaking for you to see the situation in India. And that's the comment, and I wondered if you wanted to respond to that at all.
No, I don't think so. Maybe. Yeah, we'll go on. Yeah, it's unbelievable.
At the age of 5, how long did it take you to learn enough English to cope at school?
Well, I had a sister who was brutal. She would, every night, I brought these books home and I said to her, Oriana, I'm supposed to read these books. And she sat me down and she made me read. And if I made a mistake, she slapped me across the face. But she taught me to read. By Christmas, I had 99% I had learned English, so I'd learned to speak it, but I had also learned to read. And I was an avid reader. To the point where, on Saturday mornings, I would walk from Davenport, and you'll know this, Kim, I would walk from Davenport up to St. Clair where the library was. Oh. And I would go to the public library and I would take out as many books as I could carry home. So I would walk home with a stack of books because we didn't have books in the house. The only book we had was the telephone book. And I would carry these books home and I just would read. And so I have to thank my sister, Oriana, for teaching me to read and helping me to catch up because I was behind the rest of my classmates.
Amazing. Amazing. Yeah. Going up that big hill, that big Dufferin Hill.
Yeah.
That's great. We have a few more questions here, but I don't want to keep you too long. So we do have a couple comments as well. From Murray and Joanne, they say, a huge thank you. We're so appreciative of having Dr. S on our side. And thank you, Kim, for your moderating skills. A very informative and enjoyable session. And we also have another comment, such an informative and enlightening interview. Thank you to Kim and team and Rosana and team. Thank you for offering evidence-based information and at the same time offering hope.
Yeah, you really do offer hope in the darkness and your positive, smart attitude. I love it. So now the big, I just want one more thing I'll just ask you about and then I will let you go. Is that in February of this year, you made a little announcement, which is you're gonna retire?
I'd like to.
What does post-retirement look like for you?
A recovery. On some days, it looks like hibernation. I just want to be a bear and climb into a cave and hibernate. Most days, it looks like more time just to be. I mean, really, at this age, when you work a 12-hour day, there's nothing left. Like I feel spent by the end of the day. And I just don't want to feel spent. I want to feel like I have energy to enjoy this time and this place, to enjoy my partner, 40 years, but also to enjoy my 5 grandchildren. And so we are talking about maybe relocating to Edmonton, where my daughter, my Arctic dove, she worked in the Arctic for 10 years. She now lives in Edmonton. We have 3 grandchildren there. So we're talking about going and spending more time there. So I don't know, retirement. I mean, I would love to get back to India. My friends are asking me to go back. I'd love to get back to Italy, where my relatives are asking me to go back. So time to do other things and to keep learning. I have a lot to learn.
Amazing. Well, we'll be sad to see you go whenever you do go. I don't know if it's not in the cards for you right away, but at some point. And I'm just so grateful you agreed to spend the time with me today. It's been really informative for me. And I'm really grateful to you for all the work you're doing and then for this.
Thank you. It's been fun. I haven't had time really to pause much in the last 15 months. It feels like things have always been rushed. So it's been a real treat just to spend this time with you. So thank you so much.
Okay, and I don't think I'll see you again, but I'm sure I will see an inspector at the farm in the near future taking a water sample for us.
Oh, I come too, don't worry.
Okay. Okay, good. Well, I hope to see you in the stands, and I hope to see a water inspector soon, because I will know if the world is getting righted if you're checking our water, because that means people are coming. Thank you all so much for joining us, and Lindy, thanks for all your